Morning everyone. School screening programs, learning through seeing. We know there are 1.4 million blind children across the world, and India accounts for the largest burden of childhood blindness. Talking about childhood blindness, it is mostly preventable and has a serious impact on economy and future of our nation, and timely intervention is very critical because of the risk of developing amblyopia. Hence, active screening is the rule, because there may be children who have visual disabilities who could not approach a hospital or a medical care. So community outreach is the key in diagnosing this. School screening program was started with the slogan of nurturing today for a better tomorrow. It is one of the major component activities of National Program of Control of Blindness, and childhood blindness and refractive errors are the priorities of Vision 2020. I would like to share our experience, the Little Flower Hospital experience on school screening programs. And Little Flower Hospital is a tertiary care ophthalmic facility located in central Kerala, and we cater to a population of almost covering whole of Kerala. And we had a comprehensive school screening program covering the districts of Thrissur, Ernakulam, Idukki, Kottayam and Alappuzha. This was adopted from the early 80s, and it was conducted on a regular basis from 1993 onwards. It was run in association with international NGOs and local collaborators. We followed a pyramidal model where screening by teachers at the school was the first step, and teachers were trained by our competent optometrists regarding vision testing in school setup. This was followed by screening of free eye camps by an ophthalmic team for those children who were screened by the teachers and found to have a visual disability. And those who needed detailed evaluation and treatment were referred to a tertiary eye care hospital. This are some of the photos of training of teachers, which forms a cornerstone. Qualified optometrists went to the peripheral areas where teachers were called for a workshop, and they were introduced to the basic structures of the eye and the common ocular disorders, and there was also a mock drill performed by the teachers so as to assess vision in their pupils. The Little Flower Hospital Kerala Childhood Blindness Project was a pioneer project of its kind in Kerala, and the teacher-pupil ratio was kept at 1:500, and e-charts, as I have shown, these charts were used for screening at schools. And the place for screening should have a proper lighting, adequate space, and measure 20 feet distance, mark the stand points, and the children were asked to cover the right eye and point the direction to the open ends of the E. This was repeated for either eye, and if the child cannot make out, the observations were recorded in a record, and the child was to show the referral card to the parent or the guardian and to get it signed, and to come for the eye checkup. This video shows the one of the procedure followed at one of the schools. You can see the child, or the boy is marking the 6-meter length, the standing points where the teacher stands at one end holding the chart and the student at the other end. And the problem with the screening here was the proper lighting could not arrange on that at the schools. So there could be a large number of false positives, and the teacher shows each optotype, and the pupil was to indicate the open ends of the E. That is what she is doing. And those found to have a visual impairment, or those who suspected to have a visual impairment at the schools, were called to the screening camps, which were free eye camps organized by our hospital, where we had an ophthalmic team consisting of an ophthalmologist and optometrist and a counselor. We did a subjective and cycloplegic refraction at the camp, along with flashlight examination and dilated direct ophthalmoscopy in eligible cases. And those who needed specialty clinic treatments or some other refractive errors which could not be corrected at the campsite were referred to the tertiary care hospital, where they were evaluated in detail, and spectacles were supplied at subsidized rates to all the patients, and financial assistance for surgical procedures were given depending upon the economic status of the child. This is SSP statistics of our hospital from 1996 to 2004. Every year we had treated almost around 30,000 children at the screening camps. our statistics for 2012-2013, number of children screened under the program at the free eye camps were 4,86,158, and in the above 5 districts, the total population of 5 to 15 years children was 16,24,228. So we have already seen 29.93% children. And about Kerala having the highest literacy rate, the net school enrollment in our state is close to 100. So we can ensure that almost all the children under this age group are going to schools. And number of camps conducted was 102 in 2012-2013, and children examined by the medical team was 20,522. Children with ocular disorders was 28.37%, out of which 46.2 were treated at the campsite and 53.8 were referred to the base hospital where they had treatment. And this was a prevalence of ocular disorders. Refractive errors topped the list with 71.7%, amblyopia 8.17%, strabismus cases 7.09. Vitamin A deficiency was there. It was 3.84%. But most of the cases, they had bitote spots, which did not interfere with vision in any way. There was no other cases of severe corneal cirrhosis or other issues compromising vision. Coming to the breakup of refractive errors, myopia and astigmatism. This was around 40% in the children screened. And hypermetropia, 18.6%. Strabismus, most of them were exotropes, and then followed by esotropes, and then other strabismus-related syndromes and vertical deviations. And among 412 strabismus cases, 122 underwent squint surgery at a subsidized rate at a hospital. Among 27 cases of pediatric cataract, 18 underwent surgery. Merits of the model, I would like to stress that visual problems in children can be cost-effectively treated by our program. Screening tests adopted here are reliable and sensitive. And timely recognition, as I told, is always very necessary because, to curb amblyopia. Inadequacies of the model include false positives. And because in our clinical practice, we see that a lot of children referred as vision having less than 6.9. When we are checking under optimum conditions, most of them read 6.6 unaided. And compliance issues regarding referral and spectacle use was present because though we had instructed all the children with visual disorders to report to us, there was a percentage of patients who didn't report to us. We had contacted the school authorities, but still there were a few students who didn't turn up. Also, spectacle use, once we prescribed the spectacles, there was no way to ensure compliance. And financial issues. We would like to suggest some ideas for improvement of this demerits. One is a vision testing room in schools, whereby you can ensure that proper lighting and proper distance is maintained while checking by the teachers. Next is the issue of health cards to improve compliance, and the child is to follow up every 6 months or yearly, and monitoring compliance through further follow-ups in the same school. This has some financial constraints also. Anyway, to conclude, school screening program helps in early detection and treatment of ocular disorders in children, and our program emphasizes on the active vision screening of school children in developing countries. Because unlike in developed countries, where they have specific programs at school entry, you have to check the vision, and that has to be repeated periodically. But our country doesn't have an existing program like that. So active community screening will help us to reduce this bias. But due to wide variation in socioeconomic standards in India, I told that almost all the children in Kerala are going to school, but it's not the same with all the states of India. So each state needs customized strategies, and case finding definitely needs to be proactive, and comprehensive approach is needed to ensure sustainable success. Thank you.